Welcome to this lecture on vancomycin dosing and monitoring for serious MRSA infections. We'll explore optimal strategies to achieve efficacy and safety, focusing on AUC/MyC ratios and the importance of guided dosing approaches. For serious methicillin-resistant Staphylococcus aureus infections, aim for an AUC-MIC ratio of 400 to 600, assuming an MIC of 1 mg per liter. Recommended doses are 15 to 20 mg per kilogram every 8 to 12 hours for patients with normal renal function. AUC-guided dosing and monitoring is optimal. Two methods include collecting peak and trough concentrations for PK equations or using Bayesian software with 1 or 2 concentrations, preferably including a trough. Target AUC values early, within 24 to 48 hours. Bayesian-derived monitoring can be useful for early assessment without steady-state concentrations. Trough-only monitoring is no longer recommended for serious MRSA infections. Vancomycin monitoring is advised for patients at high risk of nephrotoxicity, with unstable renal function or undergoing prolonged therapy. Monitoring frequency should be guided by clinical judgment. For empiric dosing, assume an MIC of 1 mg per liter. Achieving an AUC/MIC greater than equal to 400 is challenging when MIC greater than 1 mg per liter. Clinical judgment should guide therapy changes in such cases. Continuous infusion may be an alternative when AUC targets are unmet. For critically ill patients, consider a loading dose followed by daily continuous infusion to reach steady-state concentrations. Continuous infusion nephrotoxicity risk is similar or lower than intermittent dosing. Further studies on AUC-24 and nephrotoxicity factors are needed to optimize dosing strategies. For intermittent infusion, a loading dose of 20 to 35 milligrams per kilogram is recommended based on actual weight, not exceeding 3,000 milligrams. Monitor obese adults closely, especially when doses exceed 4,000 mg day. For CRRT patients, use a loading dose of 20 to 25 milligrams per kilogram, followed by maintenance doses every 12 hours. Monitor serum concentrations within 24 hours and adjust for fluid status. For pediatric patients, dosing is based on age and weight. AUC-guided monitoring with Bayesian estimation is suggested, aligning with adult approaches to ensure optimal therapeutic outcomes. Start monitoring within 24 to 48 hours for serious MRSA infections. Adjust dosing for renal issues, obesity, or nephrotoxic drugs, and reassess as needed, especially in cases of acute renal insufficiency. Keep AUC below 800 mg/L and troughs below 15 mg per liter to minimize the risk of acute kidney injury. Avoid doses greater than or equal to 100 mg per kilogram per day in pediatric patients to prevent toxicity. Therapeutic monitoring has evolved from relying on trough levels to using AUC-MIC ratios for guiding vancomycin efficacy. This shift ensures more accurate dosing and better patient outcomes. Daily AUC values should be 400 to 600 mg/L for optimal efficacy and minimal AKI risk. Modern methods allow accurate AUC estimation with limited sampling, enhancing dosing precision. Bayesian-guided dosing uses Bayes' theorem to optimize vancomycin regimens. It combines population PK models with individual data, allowing for early concentration measurements and adaptive dosing. Bayesian programs offer innovative schemes like front-loading doses for rapid target achievement in critically ill patients. They integrate covariates to optimize dosing for evolving PK profiles. Bayesian dose-optimizing software can identify optimal vancomycin dosages in real time to achieve AUC targets. This approach is preferred until more evidence is available for special populations. Using both peak and trough concentrations may improve therapeutic outcomes. Until more evidence is available, estimating Bayesian AUC with 2 concentrations is recommended for accuracy. Continuous infusion requires separate lines due to drug incompatibilities. This consideration is crucial in ICU settings where multiple medications are administered concurrently. For hybrid dialysis, a loading dose of 20 to 25 milligrams per kilogram is recommended, with maintenance doses post-dialysis. Monitoring levels is essential to guide dosing adjustments. In pediatric obesity, monitoring is crucial. Apply non-obese monitoring guidelines and use a 20 milligrams per kilogram loading dose by total body weight to ensure safe and effective treatment. Thank you for joining this lecture on vancomycin dosing and monitoring. By applying these strategies, healthcare professionals can optimize treatment outcomes for patients with serious methicillin-resistant Staphylococcus aureus infections.